we are going to start from the chapter 1, that is the preconception, counseling, genetics, and prenatal diagnosis. Now, question number 1. After an initial pregnancy resulted in a spontaneous loss in the first trimester, your patient is concerned about the possibility of this recurring. Which of the following is the most appropriate answer regarding the chance of recurrence? Option A, it depends on the genetic makeup of the prior abortus. Option B, it is no different than it was prior to the miscarriage. Option C, it has increased to approximately 50%. Option D, it has increased most likely to greater than 50%. Option E, it depends on the sex of the prior aborted fetus. Now we are going to check the answer. So the answer is B. An initial spontaneous abortion, irrespective of the karyotype or sex of the child, does not change the risk of recurrence in a future pregnancy. So the rate is commonly quoted as 15% of all known pregnancy. So the option is B. That is, it is no different than it was prior to the miscarriage. Now question number 2. A 24-year-old woman has had 3 first trimester spontaneous abortions. So which of the following statements concerning chromosomal aberrations in abortion is true? Option A, 45X is more prevalent in chromosomally abnormal term babies than in spontaneously aborted pregnancy. Option B, approximately 20% of the first trimester spontaneous abortions have chromosomal abnormalities. Option C, trisomy 21 is the most common trisomy in abortuses. Option D, despite the relatively high frequency of Down syndrome at term, most Down fetuses abort spontaneously. And option E, stillbirths have twice the incidence of chromosomal abnormalities as live births. Now we are going to check the answer. So the answer is D. Chromosomal abnormalities are found in approximately 50% of the spontaneous abortion, 5% of stillbirths, and 0.5% of live-born babies. In spontaneous losses, trisomy 16 is the most common trisomy, with 45X the most common single abnormality found. So a term trisomy 16 is never seen, and 45X seen in approximately 1 in 2000 births. So it is estimated that 99% of 45X and 75% of the trisomy 21 conceptuses are lost before term. Now coming back to the question 3. A 29-year-old Gravida 3 Paranot present to your office for preconception counseling. All of her pregnancies were lost in the first trimester, so she has no significant past medical or surgical history. She should be counseled that without evaluation and treatment, her chance of having a live birth is which of the following? Option A, less than 20%. Option B, 20% to 35%. Option C, 40% to 50%. Option D, 70% to 85%. Or option E, greater than 85%. Now, what the answer is? The answer is C. Miscarriage risk rises with the number of prior spontaneous abortion. Without treatment, the live birth rate approaches 50%. With treatment, successful pregnancy rates of 70% to 85% are possible in a patient with diagnosis of habitual abortion. When cervical incompetence is present and a cerclage is placed, success rates ranges as high as 90%. Now question number 4. So question number 4. 26-year-old Gravida 3 Paranot has had 3 consecutive spontaneous abortions in the first trimester. As a part of an evaluation for this problem, which of the following tests is most appropriate in the evaluation of this patient? HSG, that is hysterosalpingogram, chromosomal analysis of the couple, endometrial biopsy in the luteal phase, postcoital test, cervical length by ultrasonography. Now check for the answer. So the answer is B. A major cause of spontaneous spontaneous abortion in the first trimester is chromosomal abnormalities. So the causes of losses in the second trimester are more likely to be uterine or environmental in origin. Patients should be screened for thyroid function, diabetes mellitus, and collagen vascular disorders. So there's also a correlation between patients with a positive lupus, anticoagulants, and recurrent miscarriages. For recurrent second trimester losses, hysterosalpingogram should be ordered to rule out uterine structure abnormalities such as bicornuate uterus, septate uterus, or unicornuate uterus. Endometrial biopsy is performed to rule out an insufficiency of the luteal phase or evidence of the chronic endometritis. A cervical biopsy would be of no value in the workup of recurrent pregnancy losses. A postcoital test is useful for the couples who cannot conceive but does not address post-conception losses. Measuring the cervical length by ultrasonography is helpful in the management of the patients with recurrent second trimester losses caused by the cervical incompetence. Now, question number 5. So, the answer for the question number 4 was